Ending the opioid epidemic requires a coordinated community response. Hospitals and health systems are actively partnering with organizations and people in their communities to address the epidemic together. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hedderly, senior writer with AHA. In this podcast, Jay Bhatt, former senior vice president and chief medical officer of the AHA, serves as host and leads a conversation with Victor Dzau, president of the National Academy of Medicine, and Ruth Katz, vice president and the executive director of Health, Medicine, and Society program. They discuss how the Aspen Institute has brought together stakeholders and leaders to address the U.S. opioid epidemic in an innovative and comprehensive way.
Over the past decade, the impacts of the opioid epidemic have been felt in nearly every corner of American society. As rates of opioid use disorder, fatal and non-fatal overdose, and infectious diseases like hepatitis C and HIV have risen, countless groups have been formed to address what is an incredibly complex systemic crisis. Why was the National Academy of Medicine Opioid Action Collaborative created, and how is this effort different from others? Dr. Dzau, why don't we turn to you first?
Thank you very much, Jay. It's a great pleasure to be on this podcast with you on a very important topic. Yeah, your question about how do we get involved? Well, first of all, we all know the opioid epidemic is a crisis. It's an extensive multifactorial crisis that requires, in fact, a collective multisectoral, multi-pronged response. So back in summer of 2017, the Academy already released a number of reports on what to do in the opioid, particularly in the medical profession. Then I also participated in Ruth Katz Aspen Health Strategy Group, and we're working also on a document to talk about 5 big ideas to combat the opioid crisis. So the question Ruth and I talked about is that, okay, we both have reports, but what we're going to do about these report findings and recommendations? The best idea was to bring people together and to make sure that the great ideas are being followed through. There's another reason why I thought it was so important to do it. As the Surgeon General, Jerome Adams said, attacking the opioid crisis is like eating an elephant. I'm paraphrasing him. No one person can eat it alone. You have to have multiple people working on it together. So the idea of collective work, collective stakeholders is important. What we recognize is that there's a lot of really exciting things going on everywhere. The federal government, AHA, local governments, and many organizations, nonprofits. But there's not a place that can bring everybody together to coordinate, to know what's going on, and to find ways to work together collectively. So this is why we created a thing called the Action Collaborative. It's a public-private partnership model, and we're so glad that AHA is an important member of this, because the idea would be, if we bring together the government and the private sector and the nonprofit sector and the patient groups and academia and everybody else, we can collectively work on things, important areas which may be gaps that's not being covered by any single entity to date. So the good news, as you know, is that AHA is part of this, but we have the government Assistant Secretary of Health, Admiral Brett Dzau, who's in charge of opioid in the HHS, Ruth Katz, and Jonathan Perlin, the co-chairs with me on this initiative with the steering committee, which you're on, and we're off to races. And I'd love to tell you more about what we're doing, but let me just say we're just so glad to be working with all of you to try to make a difference in this very complicated field. Thank you.
Thank you, Dr. Dzau. Really appreciate that introduction. We really appreciate your leadership. I think in my time at the American Hospital Association, one thing that I've really appreciated about you is your ability to bring the right stakeholders together, sort of bring the puzzle pieces together so that we move forward working with Dr. Dzau and Dr. Perlin as well as bringing on the leadership and vision of Ruth Katz from the Aspen Institute, I think makes this just a great opportunity to lead collectively with different perspectives. And so I want to turn to you, Ruth. You've really been someone that I've admired for bringing voice to really tough issues in ways that we can make sense of and bring different partners together. Was there resounding support for such an effort, or a concern that is the National Academy of Medicine and Aspen biting off more than they could chew because there's so many aspects to this epidemic?
Thank you, Jay, and I'm happy to answer that. But first, let me join in thanking you and the American Hospital Association for being part of this effort. You yourself have been a leader and have helped us work very closely with the association as well as many other organizations to make this collaborative really, I think, the powerful and impactful organization that it has begun. And I'm delighted to participate in this podcast today. But to get to your question, the short answer is we did indeed do our homework. We spent quite a bit of time, in fact, deliberately over the course of several months prior to the official launch of the collaborative to ensure that we had sufficient buy-in and support for the idea. After all, if we couldn't bring the relevant groups together, what would be the purpose in just setting up some organization that couldn't move forward? But Victor and I had several calls and several meetings with leaders from associations, government agencies, different hospital systems, various foundations to explore the concept, to get their own ideas on whether or not they thought that this was a good model to move forward with and what would be the best way to proceed. Not only did we get resounding support for the concept and very much encouraged to do it, but the feedback was it would be very helpful if the collaborative could come together and focus on a few very key areas that could benefit most from the collaborative model and where we think, or where the folks we were talking to thought the collaborative could have the most impact. In other words, let's not try and do everything. Let's not try and boil the ocean, if you will. So with that feedback and that input, we have actually been able to build a public-private partnership, I think Victor mentioned, with over 60 different organizations that include leaders and representatives across the healthcare spectrum, federal and state government, education, payers, foundations, academia, and of course, very importantly, persons with real-world experience in dealing with the epidemic. So we did our homework. We think we've brought together an extraordinary group of individuals and organizations who together we think can help move forward in coming up with some very important and impactful ways for addressing the epidemic.
Thank you, Ruth. That was very well said. And from my experience, the network organizations model has really been, I think, a fantastic approach to get broader involvement in these issues. We want to advance and amplify and accelerate the right work across the stakeholders. And I think that this Action Collaborative is really moving the needle in that regard. And Ruth, again, appreciate your leadership. So, Victor, as Ruth mentioned, the Action Collaborative needed to focus and ultimately did around 4 core priority areas: health professional education and training, pain management guidelines and evidence standards, prevention, treatment, and recovery services, which I've been grateful and honored to be a part of, and research, data, and metrics needs. Briefly, what are the Action Collaborative's priorities in each of these areas?
Yeah, so these 4 areas are really important because we figure these are the areas we can make a difference. There are many areas to work on. I think one of our early meetings is to say, what's our strength? What is unique about this collective group of individuals, and how can we make a difference? So we chose these 4 areas because we believe that's what the core strength of the whole group is. Education. To my knowledge, I'm not aware of anybody working on the education like the way we're doing. There's a lot of talk about what do you need to introduce the curriculum of medical school, and if you go from one medical school to the other, you kind of see one, you've seen one. That is, what do you teach about pain management? What do you teach about addiction management? What do you teach about opioid or substance use disorder, and so on and so forth. So there's a feeling that we need to have standards throughout the medical school. And of course, medical school is only the beginning. Imagine that you're going to a residency, whether you are in surgery, emergency medicine, internal medicine, dermatology. There again, where do you teach the management of this? So we thought that ACGME, the accrediting organization that's involved with residency training, should be also part of this, as is AAMC for the medical colleges. Then there's you're in practice. So continual medical education is important. So what do you continue to teach? And then, of course, there's nurses, dentists, and other health professions. So the first thing we did is to look at health profession education training. The idea of looking at gaps, what is not being taught, where are we today, the area of looking at accreditation, certification, licensing, what is required. And then together we want to create what we call an education continuum across undergraduate, graduate, and continuing medical education across interprofession. That's what we're working on. So there's a fair amount of work now being done in terms of preparing for this and looking at literature search, publishing papers, but importantly, the groups are together talking about how to pull this whole education continuum with the certifying and licensing bodies supporting it and being able to implement the necessary experience, if you will, for people to be practicing at different stages. So that's one. The second one, which you're part of, the second one is actually pain management guidelines and evidence standard. That's another really important area. Again, we're playing to our strength because thinking about what to prescribe, how long to prescribe is a really important issue. Right now, there's a very high-level guideline by CDC say your initial prescription should not exceed 5 days or 7 days of opioid prescription. Our question really is, well, if you go to a dentist, do you need that many days? But on the other hand, if you had a major surgery and you're going home, what do you need? So the whole idea coming to us from the FDA, Scott Gottlieb then, is to say, can you help us create a framework whereby we can begin to have specificity in terms of what the prescription guideline for each condition that requires pain management and, of course, opioid management. So that's what we worked on, and we just released a report that highlights the whole issue of creating we call a practice guideline framework, whereby you can plug in that framework, take the evidence from literature, and we begin to look at 20 such conditions for acute pain treatment, whether surgical or medical, and begin to say, now you have the guidance. So we're working with one of your colleagues, Helen Bernstein, who's overseeing the multi-specialty group, and we work with a society to say, can we begin to create guidelines? So that's really important. Now, along this management, also, of course, tapering guidelines. People who are on pain treatment, how do you actually make sure that you taper correctly and without getting rebound, et cetera? So there's a lot of stuff in this space. The one that you're involved with is prevention, treatment, recovery is another really important area. Again, playing to the idea of this public-private partnership to look at what's the best practice, curation, dissemination, best practice, integrated approach. So it's also a continuum, not just prevention separate from treatment, from recovery, so that when a patient requires a treatment, there's in fact recovery services, and then there's also the way to make sure that they prevent them from getting back to it again. And here, as you know, this is quite an important area because 20 to 50% of people with substance use disorder have access to treatment, and many of them just don't have them. It's a small percent. And so the difficulty in getting access is another area that you're looking at, the patient journey, the reimbursement issue, the issue of medical-based treatment, which works, and we have a report that says you should do it and not wait to have all the ducks line up, if you will, treat the patient. And we also begin to talk about what happens, let's say, after treatment. How do you make sure there's an ongoing behavioral therapy, et cetera? So that's a very big area. And then finally, research, data, metrics. Well, we all know there's a lot to be done in trying to understand what the issues are, what to measure, how to monitor them. So this group is working on those research questions and data and metrics needs and evidence gaps. So you can see we're busy, but we are playing to the strength of the group. I think we are filling in very important gaps in this whole treatment of opioid crisis.
Jay, if I might add to what Victor has just said, I think what makes the collaborative different from other work that's going on out there is these four groups are not working in silos. They are collaborating among themselves. We want to make sure we don't come up with recommendations or ideas that contradict what one group is doing from the other. We don't want overlaps. The whole idea is to look at the epidemic, if you will, from soup to nuts, which is what these four groups together are doing. But it's important to know that they are talking to each other. This is not a siloed activity. And I think that's what is very unique and very special about the way this collaborative has been set up.
Thank you, Ruth, and thank you, Victor. I think both your comments spot on. And Ruth, I was just going to echo your comments. I think it is powerful and unique in the way that these work groups have come together. And then also, interestingly, been pushed by those with lived experience. And I think I was really struck by one of our in-person meetings where we had that group come together and talk about what it felt to go through this experience and what it felt for their community, their family, their friends to have gone through addiction and treatment and recovery, and that there's a lot that we could do. But they gave us, I think, interesting perspectives there. So could you talk about that some more, Ruth? Could you expand on the work of those with lived experience and how they're involved in the Action Collaborative? And how have you seen it impact the work and the members involved in the collaborative?
The short answer has been incredibly impactful. But I should say from the start, I think it's fair to say that the collaborative and its members felt that it was absolutely key to bring to the table in our discussions the voices of individuals that sometimes can be forgotten or silenced when we have these big policy discussions about how to deal with the epidemic. That is to bring to the table those, as you have said, lived experience. We've done that in a number of different ways. We have, for example, brought to our meetings individuals with real-world experience. We've had someone who's actually gone through addiction and is now in recovery. We had a dad who lost his son to opioid overdose to come talk to the members. These were in more formal kinds of presentations. So those kinds of discussions clearly had an impact. But last year we decided we really wanted to formalize the input that we would get from individuals' lived experiences and to ensure that the collaborative had access to this information and their input. So last year we developed a group of individuals, an advisory group, if you will. I think you were very involved in helping us put that together. We created an advisory group of people, lived experience, and integrated them within the four working groups themselves. Another great example of how we didn't just take these individuals and put them off and say, give us your ideas separately and distinct from what these four working groups are doing. We have integrated them right into the working groups. We've invited them to review and provide feedback on the work products of the collaborative overall, but of the individual working groups. We've also invited them to provide input on current and future priorities of the Action Collaborative to ensure that the work of the collaborative maintains a steady focus on the people who, after all, are the center of this crisis. There is no more important voice that is participating in the Action Collaborative. We are delighted with the enthusiasm, if you will, with which these individuals have come to the meetings, have participated, have given us their feedback. And I'm sure Victor would agree with me. Our work is that much more powerful, and I think will be that much more impactful because of their active participation in the work.
Thank you. And Victor, you've been really involved in this as well in bringing those voices forward. Anything else you'd want to add to what Ruth said?
Yeah, we're here to serve the population and the patients, and of course, their voice is so, so important. As Ruth said, that during our last meeting, one of the attendees, participants, spoke up, and it was really very moving when you imagine what they have to go through and their family members are going through. So I think it only enrich us in terms of what we're trying to do, which is serving the people and the nation and being able to get their input into design of many of the things that we do. So I totally agree that this is a really worthwhile effort in incorporating them into the work.
Great. And I think that says a lot about the intent and what the collaborative wants to do moving forward and how it's rooted in the true experiences of the people impacted by this epidemic. So a critical issue that keeps coming up again and again is stigma. And I know we heard from Shatterproof in one of our early convenings of the collaborative who spoke to this issue as well, and they're an important partner in that work. There's stigma towards addiction, individuals with substance use disorders, and treatment, including medications that people take to manage their disease. How is the Action Collaborative addressing this challenging but really important issue? Ruth, do you want to take an initial view on that?
Sure. I'm happy to jump in. And let me just underscore, Jay, what your comments began with, that we've heard about the issue of stigma over and over and over again. It is the issue that we have heard more about, the importance of addressing it than perhaps any other. I should also mention it is like the issue of research, one of our working groups. It is one of our cross-cutting issues. All the working groups have talked about it, are trying to address it in one way or another because it is so critical. And I would even go so far to say that unless and until we take on the issue of stigma in a very big way, we as a country are going to have a very hard time really getting at some of the root causes and the root issues that are going to have to be addressed to actually deal with the epidemic in a most impactful way. So as we mentioned, as we just discussed, one of the ways that we're trying to think about it and address it, of course, is including individuals with experience in dealing with opioids and their families, to include them in the work of the Action Collaborative, because after all, no one knows better what it's like to experience stigma and even just stigmatizing language. No one knows better than those individuals who are living and dealing with the epidemic, and telling us about trying to help us better understand the real way in which stigma and stigmatizing language can discourage people from getting the treatment they need and in turn limit their options for the kind of treatment they ultimately will go after. Critically important in thinking about stigma from that perspective. We've also identified people and organizations who are doing work to reduce stigma and to change the narrative about substance use disorders in general. Again, the collaborative is not looking to reinvent the wheel. If there are individuals that are out there working on this issue now, we want to build on it. We want to collaborate with them, if you will. And a great example of that is we're currently in conversations with Shatterproof, an organization, Jay, that you mentioned earlier. It's a nonprofit organization which is dedicated to reversing the addiction crisis in the United States. They are working very hard right now, have a major program, a project dealing with the issue of stigma. So we hope to be working more closely with them, take advantage of their work and build on it. And I'm sure we're going to be able to do that. But let me just underscore, this is a critically important issue that we've got to take on and figure out how to address. It's hard, but we can't turn away from it.
So there is a lot of meaningful work being done on a number of focused fronts with respect to this issue. Victor, what impact do you hope the Action Collaborative will have on the opioid epidemic?
If you look at our 4 work streams, each one should and will make important impact if we deliver what we intend and we started doing. I mean, imagine in education, that's going to make a huge difference in the knowledge of prescribers. I mean, after all, I would say we have to, as the medical profession, has to take some ownership about where we are. We're prescribing way too many opioids, and how do we get there? So having good education, knowing when to treat and when not to use opioid is important. Second, of course, the prescription guidelines can be so important because there again, knowing what condition and to use what for how long is important. The prevention, treatment, recovery is important because, after all, this is where the front line in terms of treating patients, making sure they have access to treatment, both medication and behavioral treatment and many others is important, and we need to work on this. And, of course, research and metrics. So you can imagine accomplishing all these 4 areas, I think it's extremely important. But I think we have a larger impact, possibly through this effort altogether. Why? Because as we're looking at how to work in these 4 areas, we are now mapping and creating systems map, looking at what else is going on around us, what else is going on elsewhere, and how we're connecting to the global effort, or the global effort meaning in this country, in addressing this opioid crisis. So a systems approach. And of course, we all know that you just can't do it in a fragmented in somewhat siloed fashion. A systems approach, as Ruth said, is important when not only these groups get together, but we begin to map and create a framework. Because opioid is only one of the addictive substances. Substance use disorder covers many areas. What we learned, for example, as the opioid prescriptions going down, and we are now begin to get on top of this, methamphetamine is now on the rise. And so it's not just addressing opioid, it's addressing the whole area of substance use disorder. How can we mitigate or manage future crises? And creating a framework, as we have done, is so important. There are no silver bullet solutions. It's going to take multiple systems, as we're doing. Healthcare, public health, education, financing, first responders, criminal justice, et cetera, working all in sync. And I think that we have begun this journey together. We've demonstrated it's doable. And we'd like to say in the future, this is the framework of multi-sectoral, multi-domain participation of the stakeholders to work on these issues together. So that's what I hope we'll accomplish.
Excellent. Those are, I think, incredibly important impact areas to have. And I've just seen in this work that we're really moving the needle in those areas. You talked about education earlier. Unique approach to that. We're seeing convening cultivated by those stakeholders, AAMC and ACGME taking leadership to have that conversation and move action forward. Also on stewardship, which you pointed out, that's incredibly important. And then medication-assisted treatment, which all the work groups are talking about and coalescing around, is we've got to make that easier for the field to do and for clinicians and care teams to drive medication-assisted treatment because we know it works. And then the uptake of naloxone and getting the community partners and the wraparound services together in a way that makes sense. So I think there's real opportunity for tremendous impact. And I think the collaborative has been moving significant areas of work thus far.
And again, Jay, if I could just add to emphasize again the uniqueness of what the collaborative is doing, just on the education example that Victor gave, nobody else has been able to bring together around the same table the various organizations who represent education from soup to nuts, from medical school training or nursing school training all the way through residency and accreditation. Nobody has done that, and that's what makes this different, and that's what makes it special, and I think that's what's going to make people pay attention to what the collaborative comes up with, whether it's their papers or recommendations. It's because the right people have come around the table to together try and address this problem. I think that that's what's going to bring a lot of attention to the work that comes out of the group.
Totally agree. I think it's encouraging and exciting for many of us involved in the collaborative to see that because it is working towards that higher purpose of improving people's lives around this issue. So, Ruth, from your perspective, what impact do you hope the Action Collaborative have in addition to what you just pointed out with regard to unique collaborations and activities? What are some of the other things you'd hope that we might see out of the collaborative?
Well, as Victor mentioned early on, the development of the collaborative came about in part through the work that we're doing here with the Aspen Health Strategy Group, and we're delighted that Victor is a member. The group had taken up in 2017, I'd like to say that we were, I believe, ahead of the curve in many ways, the issue of the opioid epidemic, and came up as with the consensus document, 5 big ideas on how to address the problem. I'll just mention them briefly, but they're very consistent with the work that the collaborative is doing. So I would like to think that we helped launch some of their work, that they are building on some of our work, but certainly together, both the Aspen Health Strategy Group and the collaborative all have the same goals. So let me just briefly mention what the group came up with. And I should say from the start that there's an awful lot that we know about what needs to be done. In many ways, we don't need to reinvent the wheel. If we just could take what we do know and put it into action or build on it, we think we could have a real impact. So, for example, seems very simple. Number one recommendation, number one big idea, we need to expand access to treatment. Every person with an opioid use disorder should be able to receive evidence-based treatment. And I want to emphasize evidence-based treatment. This requires, I think, expanded treatment capacity, expanding Medicaid coverage, for example, and reimbursement through private and public insurance. Secondly, The group's second big idea was to rein in the overprescribing of opioids. Both you and Victor had mentioned that earlier in our discussion. That's already happening. And we're talking about doctors, dentists as well, and other providers. They need to take immediate steps to end overprescribing while ensuring, of course, the patients who need drugs for acute pain relief are able to access to them. And I would add that one of the other members of our group, Larry Merlo, the president and CEO of CVS, I don't think we can take full credit for it, but after our meeting and after this particular big idea was put out there, CVS was in fact the first pharmacy organization to go out there and limit the amount and duration of prescriptions that would actually be filled. Thirdly, and we can't say this often enough, need to treat opioid addiction, in fact, I would say all addiction, as a public health problem. Addiction is a chronic medical problem, and we need to treat it as such. And, of course, this goes to the issue of stigma and how people think of addiction. Fourth big idea was to stop drug overdose deaths with, as you mentioned, the drug naloxone. It's an effective and easily administered therapy to counter drug overdoses. It's got to be made more widely available to first responders and others to immediately, and we can do this right now, reduce the death toll and hopefully set individuals on a path towards the treatment that they need. The fifth big idea that came out of the group really goes to the issue of, and Victor mentioned this, there is still a lot we need to learn and research that needs to be done. And one of those, of course, is we need to learn much more about how to treat pain with minimal side effects, and we've got one working group on that. But surprisingly, there really is still much that we don't know about long-term pain management, both with opioids and other pharmaceutical and non-pharmaceutical approaches. So our last big idea I would mention is, and it is completely consistent with what the collaborative is looking at, is research, data collection as well. We need a lot more of it to help address the epidemic.
That's fantastic, Ruth. Thanks for sharing that. And I know that the Aspen Ideas Festival is coming up in June. Is this going to be an issue that gets addressed there? Can you talk a bit about that?
Sure, it surely will. We're actually still in the process of putting the program together. We've actually had sessions on the opioid epidemic and addiction more generally at the Aspen Ideas Health Festival over the last several years. We will surely focus on it again this year. Hopefully, we'll be able to say we've made a little bit of progress from years past, but it remains a huge public health issue, and we'll certainly want to address it again this year.
Excellent. So, Victor, let me turn to you and ask the question, how can people learn more and be involved with the work of the Action Collaborative?
Well, first of all, we welcome everyone to know more about us and actually get involved. So feel free to reach out to Ruth, myself, to a number of people. If you happen to know how to get hold of us or you know us, we most welcome this. But there's also another way, is look at our website, which is nam.edu/opioid collaborative. So you can find more information about our work, read the products we produce when they are available, sign up for our listserv to get email updates about publications, upcoming events, listen to future podcast episode collaborations between AHA and Action Collaborative, and read more about our members who are leading this effort. So all that is available. Our next public meeting will be on May 21st in Washington, D.C. at the National Academy of Science building on Constitutional Avenue in D.C. It's open to public. We invite anybody who's interested to register to attend. The meeting will also be live webcast and will be recorded and posted on our website after the event concludes, in case you're busy and couldn't join us that day. We really encourage everyone who's interested to get involved. We need to hear your voice and get your buy-in in order to move some of the critical solutions ahead and really put this crisis to rest.
Let me just add to what Victor has just said. As we like to say at the Aspen Institute, good, big, impactful ideas can come from anywhere and from anyone. So while we do have our members of the collaborative who are bringing their expertise and experience to the table, members of the public do have an opportunity to participate in the process. And as Victor said, we welcome comments, suggestions, and there are opportunities to do that. And you guys have big ideas out there as well, and we look forward to hearing them.
Fantastic. I think the website has many wonderful resources. And actually, there's a great video that outlines a journey of a family that might experience this issue. And I thought it was well done. And that and a number of other resources that are coming out of the work groups are really going to be meaningful for the field. So I encourage you to take a look. Victor and Ruth, thanks for your leadership. Really appreciate Admiral Dzau and Dr. Perlin, their leadership in this, and also the work group and the steering committee chairs who've put in a lot of time and effort. They've done excellent work, and we're really just grateful to have this community and space to make a difference on this epidemic.
Jay, that includes you. Thank you for your leadership on this issue as well.
Ditto from me, Jay. Thank you very much.
Thanks so much. Well, the American Hospital Association is grateful to be a partner in this important effort. We want to support the field and the stakeholders really move the needle on this and stem the tide. And so we're really excited to be a part of it. Thank you all for listening. Learn more about the NAM Opioid Action Collaborative online and join us for future episodes featuring members of the collaborative. You're going to learn a lot and it's going to be fantastic. Thanks so much, everyone.